little message. I'm Lindsay Jarvis, and I'm going to be the chairperson for this session for the psychology. So first up, we are going to have Linnea Taylor to present.
It's pronounced Linnea.
Linnea, okay, I'm so sorry.
It's fine.
So I'm going to give a little bio about Linnea. So Linnea is a double major in art and nursing at Southwestern Community College, located in Sylva, North Carolina. And Linnea is halfway through her art degree and 1/4 way through her nursing degree. She is an honors student with a 3.8919 GPA, and she has held 3 art shows throughout her school. And you are going to be presenting on Vincent van Gogh's and possible illnesses and art therapy. So we're excited to hear your talk.
Is it time for me to start?
Yeah, sorry. And let me know if you can't screen share.
Vincent van Gogh, possible illnesses and art therapy. Part 1, Vincent van Gogh's biography. Childhood. He was born March 30th, 1853. He was raised in a small village, Zundert, Netherlands. He had 5 younger siblings, 2 brothers, 3 sisters. Others described him as miserable, annoying, self-willed, and moody. He spent most of his childhood alone, wandering around in nature. He had a possible head injury as a child. I did not find a lot of evidence to support that. There were just a couple articles that said he may have had a head injury. There was no real evidence. His first job. So when he was 16, he got a job as an art dealer for a company that his uncle was a co-founder of. And when he was 20 years old, he actually lost that job because he was too gloomy, avoided social situations, alienated his family, and was really obsessed with religion. First failed romance. In 1874, he was rejected by a woman who was already engaged. This forced Gough to become depressed, disappointed, frugal, and solitary. Theology and leaving religion. So he did some missionary work in a poor village called Borage. And he took the Bible teachings a little too literally by giving away all of his possessions. And so the church actually dismissed him because of that. And he kind of felt a little betrayed. So he left the church and became agonistic. And he actually stated that being a pastor was the worst time of my life. His second and third failed romances and alienation. He was rejected by his cousin Key, and after the rejection, he threatened to burn his flesh with a lamp if she continued to reject him. He lived with a prostitute for a year. She had 2 children. He wanted to marry her, but his family disapproved. And then he decided to become an artist, which alienated his family because they thought, the starving artist thing, they thought it was, below them. He moved in with his dad in 1881, and he became interested in his neighbor named Margaret. She attempted suicide by poisoning, and it took a huge toll on him, the Hague. After leaving his father, he moved to The Hague, which is a city in the Netherlands. He went to museums and met other artists. He developed feelings of sadness. He worked to improve his artistic abilities, and after several months, he just crashed from exhaustion from doing so much art. Theo, Paris, and alcohol. In 1886, he moved in with his younger brother Theo, and while he was there, he developed episodes of sudden terror, unconsciousness, and irrational temperament. He drank alcohol, and him and his brother quarreled frequently, but he continued to make art. Arles and mental illness. So in 1888, he moved to Arles, which is a city in France, and he said his arrival felt like he was having a stroke. He began to drink again, and his symptoms worsened, so he drank more. He had periods of exhaustion and creativity. where he felt anxiety, emptiness, fatigue, restlessness, and he continued to do art. Studio of the South and Paul Godwin. So also in 1888, he founded the Studio of the South, which was an organization dedicated to Impressionist artists. And an artist named Paul Godwin joined the group. They began to fight and couldn't stand each other. So when Godwin tried to leave, Go got mad and threw a glass of whiskey at him and chased him around with a razor before removing his ear. But a report actually says Go did actually not remove his ear, that Paul Godwin actually cut his ear off with a sword. So his hospital stays. So the day after the removal of his ear, he was hospitalized for 3 weeks. He was placed in isolation for 3 days, where he had feelings of agitation, hallucinations, and delusions. He also experienced memory loss of the event with Godwin. He didn't remember anything that happened, like didn't remember throwing the glass at him, didn't remember the ear removal, nothing. And he was also diagnosed with epilepsy. And then his second hospital stay, he had the same symptoms and was also placed in isolation a second time. And he could not recognize faces of the people he knew. And the third hospital stay, he was also placed in isolation for a third time and experienced severe anxiety. His fourth hospital stay. This hospital stay lasted for 1 year. He arrived with no will or desires, and he had some odd behaviors like eating paint and dirt. They're not really sure if the fact that he ate paint was a suicide attempt. They didn't know if it was just an odd behavior, if he was actually attempting suicide. But he did have mood shifts while he was there between peace and hopelessness. He had a disturbed mind, was distraught, discouraged, and he was discharged with the incompatibility to work and had incoherent words. His breakdown and suicide. So his brother Theo got married and had a child. Go was overjoyed for his brother, but he felt more burdensome to his brother financially. And because of this, he committed suicide at the age of 37 because he wanted to be less of a burden to his younger brother Theo. He actually shot himself in the chest and he died in the hospital 2 years later. His last words were, "The sadness will last forever." And Vincent van Gogh and Possible Illnesses Part 2. So possible illnesses. So what I did is I went through the DSM-5 and I looked at all the symptoms, and when I went through my research and looked for what people speculated that he had, and the ones I've highlighted are the ones I've concluded he may have had. So he probably had autism spectrum disorder, alcohol use disorder, and alcohol withdrawal. Bipolar disorder, specifically bipolar 2 disorder. He had may have had major depressive disorder, but that one was ruled out. He probably had borderline personality disorder. Schizophrenia and brief psychotic disorder were also ruled out, but he did have temporal lobe epilepsy. So autism. The symptoms of autism are an inability to engage with others, share their thoughts or feelings, trouble sharing thoughts and feelings. Developing, maintaining, and understanding relationships is difficult. People with autism can have odd motor movements. They can also have repetitive speech patterns. They're resistant to change. They have ritualistic behaviors, and they're hyper-focused on tasks. The ones I've highlighted are the ones I have concluded that Go have had. So the alcohol and this use disorder and the withdrawal. So for the alcohol use disorder, alcohol is taken in large quantities, unsuccessful controlling drinking habits and cravings, spend time trying to access alcohol, causes interpersonal issues, keep using the alcohol even hazardous to your health, and the alcohol withdrawal is hyperactivity, insomnia, nausea or vomiting, hallucinations or illusions, psychomotor agitation, anxiety, and generalized tonic seizures. And then his bipolar 2 disorder. There's two things with bipolar disorder. There's hypomania and depression. And so for the hypomania symptoms, there was elevated mood, increased energy, inflated self-esteem, which he did not have, decreased need for sleep, more talkative, racing thoughts, distractibility, unreasonable goal setting, and risky behavior. I concluded he did not have. For the depression, he did have a depressed mood, diminished pleasure in activities. He didn't necessarily have that because he continued to do his art. Weight and appetite changes. There were periods where he didn't eat and he did lose a lot of weight. Insomnia, he did have trouble sleeping. The psychomotor agitation he didn't have. He did feel fatigue. He had guilt, worthlessness, and an inability to concentrate. So borderline personality disorder. You avoid abandonment. You have unstable relationships. You alternate between idealization and de-evaluation. You have an unstable self-image. There are self-harm behaviors and possible suicide, chronic emptiness, anger control issues, paranoid ideation, and dissociative symptoms. And for the epilepsy, cognitive and or emotional manifestations, panic attacks, gastral issues, loss of consciousness, irritability, headaches, confusion, euphoria, anxiety, and depression. And part 3 of 3, Van Gogh and art therapy. So art therapy, the definition is combines the fields of art and psychology. It's a form of psychotherapy that uses art materials as a communication method. And it's the functions of art therapy are to improve cognitive function, increase self-esteem and self-awareness, develop emotional resilience, promote insight, improve social skills, and resolve conflicts. The materials in art therapy, traditional is drawing, painting, collage, and clay. Non-traditional materials include crafts, photography, videos, and digital art. Art therapy in the brain. Both hemispheres of the brain are used in emotional expression. The most impacted part of the brain is the lymphatic system, which is responsible for survival, instincts, and reflexes. Neuroplasticity and trauma. Neuroplasticity is art. So propels healing of deficits in the brain. The brain is malleable and flexible. The brain can rewire and renew itself, and art helps rewire the brain by improving cognitive function and performance. Art helps mobilize and stabilize memories, which are important in the healing process of trauma. It's also art is also a structured way to re-experience traumatic memories and process them. And it also helps control emotions and thoughts. Art therapy and mental disorders. Mental illness affects the ability to feel, think, and have stable relationships. Art therapy is a non-pharmaceutical treatment for mental illness. It can improve your quality of life. It can promote self-sufficiency and satisfaction. Provides hope to the hopeless, can help people develop purpose and meaning, and can increase value and self-esteem. So autism spectrum disorder and art therapy. So art therapy helps people who have autism spectrum disorder communicate, socialize, and connect with others. They can express their emotions, and it can improve socio-emotional skills. It also helps reduce anxiety, depression, and stress. So for Van Gogh, art therapy helped him communicate his thoughts and feelings, which he struggled with. And he also had a way of forming connections with others through his art. Alcohol use disorder. So art therapy helps lower stress, relaxes the body, reduces emotional tension, improves self-esteem, boosts thinking, improves general functions, and controls cravings. So for Van Gogh, it helped ease the symptoms. It was one of the positive coping mechanisms he had. It lessened his cravings for alcohol. He was less distracted in his mind, and he often feared that he would relapse, but art kind of helped him keep under control and not relapse into drinking alcohol again. Bipolar II disorder. So art therapy can help reduce stress and anxiety for people who have bipolar disorder. It can improve their self-esteem, improve brain functioning, helps them monitor their episodes, and balances their mood. So for Van Gogh, it helped control his mood shifts. It helped relax his mind. It decreased his racing thoughts, and it reduced his symptoms overall of bipolar disorder. Borderline personality disorder. So art therapy helps people who have BPD with their self-harm tendencies. It lowers suicidal ideation. It provides relief from guilt and rejection, reduces stress and anxiety. So for Go, he used art, not self-harm, and it distracted him from those self-harm thoughts and helped reduce his stress and anxiety. So psychosis. So art therapy helps people who experience psychosis through help them differentiate reality from hallucinations, and helps stabilize their psychotic symptoms, increases self-esteem, and improves social skills. So Van Gogh, it helped him kind of maintain hallucinations and delusions, and it helped him process his experiences and reflect on past events. So the epilepsy. So art therapy can reduce for people with epilepsy, art therapy can reduce chronic stress, control emotions, helps restore identity, improve self-esteem, self-worth, self-respect, and can restore confidence. So for Van Gogh, it helped to reduce his anxiety and controlled his fear of having another seizure. Van Gogh and art. Art was Van Gogh's greatest love. He couldn't survive without it. It kept him sane. It gave him a purpose. It gave him some power back and helped him express his deepest emotions in a positive way. Conclusion. Tragedy. So for my conclusion was that Van Gogh had a life of both tragedy and inspiration. You know, he was a miserable child, addicted to alcohol, couldn't work. He lost the only friend he really ever had. Couldn't find a stable romantic relationship. Had self-harm tendencies, and committed suicide. But he also produced art, no matter how bad he felt. And he also grew inspiration from his misery. He got most of his ideas while he was in these negative moods. He had unconditional love from his brother Theo, and his mental illness may have controlled him, but he controlled his mental illness through art.
Thank you, Linnea. That was such an interesting presentation. So are there any questions from our audience before we move on to the next presentation? All right, so for sake of time, I think we should go ahead and move on. Thank you so much. That was such an awesome presentation. I really enjoyed hearing about it and hearing about Vincent van Gogh. Oh, actually, we have a question. Have you witnessed anyone in real life who's benefited from art therapy?
I would say me, myself.
Yeah. All right. So our next presenter is Amari. Is that correct?
Amare.
Amare. All right. Sorry. So I'm going to give your bio, and then you can go ahead and screen share and let me know if you aren't able to. So okay. Amare Reed double majors in psychology and political science with a minor in communication is one of the psychology disciplinary honors program at UNCG. During her years at UNCG, she has worked as a student research assistant in Dr. Dana Turan's Adult Cognition Lab and Dr. Jennifer Kaufman's Cognitions and Context Lab. And your title is, the title of your presentation is Examining the Role of Subjective Age in Older Adults' Work, Activity, and Everyday Engagement.
Perfect. I'm going to share screen now. Awesome. Well, good afternoon, everybody. So, as mentioned, my name is Amari Reed, and this is my presentation on examining the role of subjective age in older adults, work activity, and everyday engagements. So, why is this important? Well, the workforce is changing a lot faster than we expect. And according to the US Bureau of Labor Statistics, the workforce is supposed to increase by 8.9 million by the year 2030, which is a huge number, and that's only 7 years away. So for that kind of increase, it's time that we start paying attention to who we have in the workforce. And even more stunningly, the number of people aged 75 and older is expected to increase by 96.5% within the same time frame. So we're expected to see a big influx of older adults in the workforce past the years of retirement. So I think it's important that we start to look at how we can make the work environment better for them. So like I mentioned, the years of dreaming of retirement at age 65 are long gone. Even now, we probably all know someone over the age 65 that's still working and probably still gonna have to keep working for a few years. So with all these other people in the work environment, I think that we should find ways to be more conscious and better understand the impact working and work participation can have on individuals' self-perception and their well-being, especially regarding age. So the purpose of this study is to explore the relationship between work participation and how everyday social, physical, and mental engagement can contribute to subjective and successful aging in older adults. So, this research stems from Dr. Torin and Matthew Hughes' Adult Cognition Lab, where I was a research assistant, and their research examines the impact and influence of everyday behaviors on subjective age in older adults age 60 and up. And they propose that one's environmental context can influence fluctuations in daily subjective age. And their findings can suggest that there is evidence that will show subjective age is influenced by everyday behaviors such as work participation, which I'll be looking at in my study specifically. So I've been using this term subjective age a bit in the past couple of minutes, and you're probably wondering what is subjective age. So I'll tell you, and subjective age refers to how you feel about your age, like how old you feel. So one's perceived age, whereas your chronological age is how old you really are. So for instance, my chronological age is 22. I'm 22 years old, but I feel a bit older. I might say I feel 25. So you would say I have an older subjective age. And previous research from Monte Parr has shown subjective age can be used as a predictor of behavior in some instances, and it can influence personal priorities. More specifically, her research has found that subjective age, those with a lower subjective age may influence more personal and social behaviors, whereas chronological age is an indicator of more behaviors that are usual for older adults, such as retirement, like someone with an older subjective age might be looking more into retirement and other behaviors such as that. And so other previous research from Chibi and colleagues have found they focus on studying age-related differences in the dynamics of the workplace. As in my study, I'm also looking at it from a work perspective. So that's where some of this research I'm going to be just talking about is looking at it from as well. And their results show that older workers were more likely to function better at an emotional level in the work environment. I know there's this big stigma around older adults in the work environment that they might be more frustrated or not be able to handle it as much as younger adults. But research has shown that that's not necessarily true. And older adults have the capability to effectively participate and navigate workplaces, both emotionally and through their experience. I think we've all had instances where we've been the new person to a work environment and didn't really know how to handle it, but you're able to talk to someone else that worked there that might have been a bit older and had the experience and knew what to do. So although there's this big stigma around older adults in the workplace, that's just a stigma. It's not actually true. They can function in the workplace even better than younger adults in some instances. So I think it's very important for us to start looking at how to make the work environment a better place for them, since they are so important to our workplaces. Another previous research from our mentor has shown that subjective age bias and age group identification can influence daily well-being in older adults. And there's some more terminology in here you might not be familiar with. So subjective age bias is the difference between one's chronological age and their subjective age. And age group identification refers to the age group one ones to identify with. Say if they have a lower subjective age, they might identify with a younger age group. And then their research shown that on days that participants reported a lower subjective age, they tended to also report higher levels of well-being on those same days. So their research highlights that there could be a relationship between subjective age bias and well-being was stronger for individuals who identified more strongly with their age group. So this highlights how daily fluctuation in subjective age are relevant in predicting one's social and cognitive engagement in the workplace. And further research on the topic from Kunz and colleagues has shown that workers with a lower subjective age related and socialized more with their younger coworkers based on feeling more similar to them. So for instance, their research has shown that employees that reported a lower subjective age might talk to their coworkers who happen to be younger. They might have more to discuss, whereas these employees might be looking at ways to get raises or planning on going on vacation, whereas those with a higher subjective age might be focused more on things that are part of later in life, like retiring and just being done with the work environment. So this research highlights how subjective age can influence behavior and socialization within the workplace and possibly beyond, as further research has shown as well. So as I basically just mentioned, subjective age can influence social behaviors and reinforces the theory that subjective age is a predictor of everyday behaviors. So from my study, I'm expecting to find two main hypotheses, and the first one being that older adults with a higher work participation will also report a lower subjective age. And secondly, older adults with a higher work participation will report higher perceptions of successful aging than adults with lower work participation. And so what will this study add to basically everything else I mentioned previously? So I want to look on exactly how the relationship between subjective age or participation, just in general, see if there's any correlation there at all. So I want to look at how does work participation and engagement in social, mental, and physical activities contribute to how old a person feels daily in their general sense of well-being. So for the study, we're looking at a few measures, including work status, hours worked, and mental and social engagement. And we're getting that through our demographics survey. And we're also going to be using summary scores from the activity lifestyle questionnaire. And as I mentioned earlier, we're looking at well-being in older adults. In order to measure that, we're going to be using results from our awareness of age-related change, which we call the AARC. And so those are our measures. And so for our participants, we have 204 older adults, supposed to be age 59 and older, so not 69, 59. And in total, 204 older adults. And here I have a little chart that I thought highlighted the most important demographics that we have. So the average chronological age was 69, and the average subjective age was 55. So as you can see, a lot of people reported feeling younger than their actual age. And the average hour of reported work hours per week were 11 hours. And then I also wanted to highlight the gender differences in our participants. There's a majority female, almost 74%. So although this study specifically isn't looking at differences within gender, since there's such a big difference, I thought it was important to highlight that before we look at the results. And for the procedure, so for the study, we have our participants, after we reach out to them, they take a cognition test to see if they're able to be a part of the study. It's pretty simple. Most people pass, and they do a pre-test. And then throughout the week, they get 6 texts a day. And they're supposed to answer at least 3 throughout the 7 days, where we get their current activities and they report the subjective age and what they're doing at that moment. And there's experimental manipulation within some of the surveys. However, for my study specifically, we will not be using the experimental manipulation. As I mentioned earlier, this study takes all this data and materials from Dr. Torrance' lab. So they're using the experimental manipulation, but I will not be. And after the week, they take a post-test and an exit survey. So for the results, there wasn't much correlation between work hours and subjective age discrepancy. And let me tell you what subjective age discrepancy is. So that's your chronological age minus your subjective age, divided by your actual age as well. And for our study, the average subjective age discrepancy was 0.2, which means on average, our participants felt 20% younger than their actual age. So most older adults, based on our studies, tend to feel younger and have a lower subjective age. And in this graph, we have our 11 job categories, so retired, other, NA, volunteer, home service. For NA, those are people that just left the question of if they're working blank, they didn't answer. A lot of people were retired. As I mentioned, they're over the 59 and older, most of them are going to be retired. But as you can see, these graphs show a line of regression. So the slope on our regress SAD, which is subjective age discrepancy, compared to the hours worked. And as you can see with these graphs, most of them are nearly straight. There's not much correlation. It's pretty low when you break it down throughout the different job categories. Oh, there's a big difference in sales. But another issue with this is there's not many people in each category, each job. So there's maybe 4 people in the sales category. So it's a lot easier to see a line regression in something with such little sample. But in other categories, such as business, there's a slight positive line regression. So that would be saying that people that worked more hours per week also reported a more positive SAD, which means a lower subjective age. So they felt younger the more they worked. But you don't see that in many categories, and most of them are basically a straight line. So the data shows that the hypothesis was essentially no, and there's still more research to be done in the future. And for the second hypothesis regarding the well-being and their reports of their successful aging, as you can see here, this is another regression line. It's still for the gains loss, so they have a positive view of their aging. It's essentially no as well. The dots all over the place, and it's just a straight line. However, when it comes to them viewing their aging as negative in the loss section, we see a negative regression line. So that's saying those that reported a higher subjective age reported less negative viewing of their aging as well. And we're still going through the data and looking for more differences. But at the moment, this is what we have so far, and it's showing that there's not much difference in the positive viewing of their aging, but there is in the loss. So for discussion, although my original hypotheses were not proven through the data, I do still think this is important work still be used to better understand the psychological impact of the increase of all these older adults staying in the workforce. And it highlights the importance of finding ways to elicit a lower subjective age in older adults. As highlighted on the AARC graph, those with the higher subjective age reported less negative views of their aging. So that highlights that having lower subjective age can be beneficial for older adults. And as Stefan and colleagues in 2013 found in their study, they found ways to elicit a lower subjective age in older adults. And I think that using those findings and these, we can find ways to maybe encourage older adults to feel younger in the workforce, and that can encourage more communication and just a better work environment for older adults. So the current and previous findings will enable us to establish healthier working conditions and environments for older adults that can encourage lower subjective age while also being mindful of the psychological impact work status and engagement can have on individuals. So limitations in future directions. There were a few limitations for this study, such as we began during the COVID-19 pandemic, where a lot of people were no longer going to work, really working from home, not having as much engagements, or maybe they even just quit their job or weren't working at all. So that could have had an impact on the results. So that's something to look at. And there's also no comparison to other age groups. As I mentioned, everyone was 59 years or older in this study, so we don't have any comparison to how these results might look in younger age groups. So we're looking for ways we could fix this in the future, and maybe we can have more age groups, more comparisons. So that's something we're looking to do. And for my acknowledgements, I want to acknowledge the Adult Cognition Lab and Dr. Dana Torin and Matthew Hughes, and our lab manager, Kayla, and some of the graduate students in the lab too, Sydney, Jack, and Paige. Some of the other research assistants, Azra and Anita. This is a picture of us. I don't know if this is blocking for you guys too, but there's everyone. And also the Graduate Research Scholarship Contributing Office for my ERSCO grant that helped fund this research, and UNCG. And so if anyone has any questions, I'm here. Lindsay?
Yeah. Oh, sorry. I was doing the clapping.
Oh.
No, it's okay. No, thank you so much for such an interesting talk, and definitely a novel topic that needs to be studied more, like you were saying, as we see older adults staying in the workforce longer.
Yeah.
Is there any questions from the group or the audience? Well, I have a question related to, so you had your results broken up by different occupations. So do you think, and I know you said there wasn't really anything significant, mostly because there wasn't enough people per category, but do you kind of have a hypothesis of what type of occupation might lead people to have more like the positive subjective age discrepancy? So like older adults feel younger based off of it?
I would say based on previous research, jobs where they're engaging with more people and interacting with more people, I think would lead to a lower subjective age, because they're socializing more, they're having the chance to talk to people and just be more involved in things with other people, which tends to lead to a lower subjective age. So that's what I would think. That's why I feel like in the business category, as you see, no, sorry, the sales category, they're reporting lower subjective ages as well. And sales, you talk to a lot of people, so I think that makes sense.
Yeah, awesome. I'll read a question from the chat. It says, does physical health and well-being have an effect on subjective age?
I don't know. I don't want to give an exact answer. I'm not too sure exactly, but I think it would. I think that if you're healthier, you have more chances of being able to go out and do more things instead of just being in the house or in the hospital or something where you don't have a chance to socialize and really interact more.
Yeah. Well, awesome job. Thank you so much. We're gonna move on to our last presenter.
Yeah.
All right, thanks. So our last presenter today is Sophia O. So Sophia is a senior at the Middle College School at Durham Technical Community College, pursuing an associate's in science and a high school diploma. After graduation, she plans to earn her bachelor's degree in biology, and then she hopes to attend either medical school or pursue a career in marine medicine. Sorry. And your title, or your talk's title, is The Development of Tic Disorders and Their Relationship to Other Neuropsychiatric Disorders. So yeah, you can go ahead and screen share and let me know if you aren't able to.
Hi, my name is Sophia, and I'm excited to share my project, the development of tics and their relationship to other neuropsychiatric disorders. Because this is such a large topic in general, I have broken it down into 4 points: an introduction, the causes of tics, co-occurring disorders, and finally treatment. So for the introduction, I'll be going over the basics of tic disorders and their prevalence. Tic disorders are commonly defined as repetitive but involuntary twitches, movements, or sounds. They range in severity and symptoms, and there can be motor tics and vocal tics. Symptoms of motor tics include involuntary kicking and head jerks, while symptoms of vocal tics include screaming, involuntary screaming, and humming. The most commonly known form of the tic disorder is also the most severe, called Tourette's. In the US alone, tic disorders affect 1.4 million people, and 350,000 to 450,000 people are diagnosed with Tourette's. For the prevalence, it is twice as more common in Caucasians than minorities, although the reason why is unknown. It is 3 times more common in boys than girls. And 1 in 5 children have tics that disappear or decrease in their teenage years, causing them to often go undiagnosed. So looking into the suspected theories and genetics of tic disorders. There's no confirmed cause of tic disorders. However, research has compiled several theories over years. The most probable cause is genetics, and the genetics cause a change in the parts of the brain that control movement, which leads to tics. And there's a suspected autosomal dominant pattern of inheritance that are caused by a single gene variation. However, newer research contradicts this theory. And now scientists are more focusing on a mix of genetic and environmental factors as the cause of tic disorders, including triggers like stress and physical experiences. The gene that is most likely mutated causing tics are either dopamine receptors and transporters, serotonin receptors and transporters, or chromosomal aberrations. The reason why genetics is the most probable cause of tic disorders is there's a 50% chance of children inheriting tics, as it is believed to be a dominant gene, and a 0.25 to 0.77 heritability of concordance rate, or 10 to 100. There's a 10 to 100 times more likely for tic disorder patients to have a first-degree relative that has a tic disorder than not, and 95% chance of twins both inheriting tics. Co-occurring disorders, the relationship between tic disorders and other neuropsychiatric disorders. So tics and Tourette's are believed to be the tip of the iceberg in neuropsychiatric disorders. The Tourette International Collaborative Genetics has found that there's the same genetic variation presents symptoms of OCD, ADHD, and autism as it does tics. And 79% of the children with the tic disorder have also been found to develop another neurodevelopmental condition. 57.7% of Tourette's patients have 2 or more psychiatric disorders. 42 of them have OCD, and 61% have ADHD. However, it is believed that OCD actually moderates the severity of tics, whereas anxiety, mood disorders are linked with the increase of tics. However, they also decrease the risk of substance abuse, contrary to belief. Treatments. So there are 4 main groups of treatments, as tic disorders are not curable. Medication, which often includes antipsychotics, movement reducers, anti-seizure medications, and cognitive enhancing medications, as well as therapy, which ranges from behavioral therapy and habit reversal training to deep brain stimulation. However, awareness and controlling the environment is believed to be the best treatment. Awareness being avoiding negative reactions and preventing suppressions, because especially in children and teens, whenever a child or teen suppresses their tics for too long, especially at school or with their friends, when they get home, it explodes into an uncontrollable tic attack, worsening the condition over time. And as for environment, it is best to educate the patient about their tics and keep a calm environment. The issue with the current tic medications is there are several side effects. For medication, the variety of medication is linked to weight gain, severe depression, irregular heartbeat, rage, dizziness, difficulty breathing, drowsiness, confusion, and addiction. Methylphenidate is a stimulant that is often prescribed to ADHD patients. However, that medication has shown to cause development or worsening of the tic disorder. For therapy, the side effects of habit reversal training or comparative behavioral intervention of tics work to identify the source of a person's tics and then avoid it. However, it's commonly, the rebound effect is commonly seen where the patient actually has more tics, and a suppression may result in the appearance of a new tic and an increase in severity of non-target tics. For example, if anxiety causes a person's tics, when suppressing that or avoiding that, they may develop tics from an animal or anger, some other source. Deep brain stimulation is becoming more common and is a newer treatment. However, it's only used in the most severe cases of Tourette's because of their dangerous side effects. It includes an implanted electrodes connected to a neurostimulator, which sends high-frequency electrical impulses to the brain, stopping the tics. However, there are so many high complications, included infections from the implanted device, the device fracturing or breaking, and the possibility of worsening of cognition or mood and suicidal thoughts. There's also the danger of bleeding or strokes, numbness, and changes in visions or speech. So there's so much more to be researched on tics because it's such a large category and so much variety, but I just researched the overall view on them and how they're related to other neuropsychiatric disorders. So does anyone have any questions?
Thank you so much for your presentation. It was awesome. Yeah, is there any questions from the audience? Someone said they learned a lot. It was fascinating.
Thank you.
Yeah, I have a question.
Yeah.
So you don't have to feel like you have to be right in this question, but because I don't know the answer at all for sure. But what do you think should be the first line of treatment for tic disorders? You talked a lot about different treatments options. So which one do you think should be like the first one we should think about in treating?
I think awareness is sadly the most effective because I have a tic disorder myself, as does so many of family members, but medication has so many dangerous side effects that lead to different disorders, and therapy works differently for different people. So making the people around you aware that a tic disorder is not dangerous, it's not bad, because when people have put the pressure on the patient of you have to stop doing that, you have to stop tapping your foot, you have to stop humming, then they end up suppressing it and exploding. So I think making people aware of it so society becomes more accepting of it and not so judgmental is actually the best treatment and should be the front line.
That's a really great answer. Yeah, thank you. Is there any other questions from our audience? All right. If not, well, thank you to all three of our presenters. Yeah, I really enjoyed hearing all your presentations and learning a lot. Yeah, definitely put the clap back up, right? But yeah, so thank y'all so much.